Hi, everyone, and welcome to our event today. We're going to give it a few moments as folks join our live stream. Thanks so much for spending your afternoon with the National Accreta Foundation for our first ever Accreta Expert Series. Hi there, thanks for joining our live stream. We're so thrilled to have you with us today. As you're joining, please tell us in the comments where you're joining our live stream from. We're going to get started in just a moment or two. Hi, Deborah. Thanks for being here all the way from California. Hi, Shelly from Tennessee. Great to have you here. Hi, Christine from Pittsburgh. As you're joining us, remember that we are here for you. This event is your event, so we'd love to see your reactions and comments as we progress through the live stream today. And again, just let us know where you're joining us from in the comments. I see Jackie joining us from the UK. Thank you. I'm not even sure what time it is there, but I'm so glad that you've made the time to be with us. Lenore, thanks for being here from California. Bob from England. Rosanna from Saudi Arabia, is it? Wonderful to have our international and national Accreta supporters and survivors with us today. Well, we're going to go ahead and kick off our event. My name is Jory Novotny, and I'm an Accreta survivor from Columbus, Ohio. As volunteer social media manager for the National Accreta Foundation, I'm proud to be here with all of you today for this interactive live stream event. We've already had the most impactful Accreta Awareness Month yet. There's still time to donate, create or promote your AAM fundraiser, order your Accreta Strong gear, give blood, share your story, and spread awareness. I'm popping up now in the stream a link where you can go see some of the actions that you can still take this Accreta Awareness Month. Visit that page to see tips and info on how you can get involved this month and year-round. Like many of you who first learned about Accreta when you were diagnosed or after you gave birth, the first time I heard the word Accreta was hours after I'd given birth and wound up in the ICU. Eventually, I found helpful information and a community through the National Accreta Foundation, and it means a lot to me to be a small part of bringing expert information to patients, survivors, families, and providers. So please share your questions, comments, and reactions throughout this event. This is your space. And with that, I'm pleased to turn it over to Kristen.
Hi, everyone. I'm Kristen Terlizzi. I'm a placenta Accreta survivor. I'm coming at you here out of Northern California. And I'm also a co-founder of National Accreta Foundation. And I just want to thank you all so much for joining us today and just give a big shout out for everyone who's participating in Accreta Awareness Month. It's been amazing. We've been seeing you sharing our posts, wearing your gear, raising funds, and doing so much to get the word out about placenta accreta as one of the fastest growing life-threatening complications of pregnancy. In honor of Accreta Awareness Month, I am so excited to introduce National Accreta Foundation's new Accreta Expert Interview Series. And this series really showcases the researchers, the care providers, the public health experts who are leading the way in advances related to the placenta accreta spectrum. And this series is something that we in NAF have wanted to do for a really long time. So I want to give a big thank you to Dr. Brett Einerson, who's here with us today. He is the perfect choice for being our first Accreta expert to join the series. And to tell you a little bit about Dr. Einerson, he's an assistant professor and a maternal fetal medicine physician at the University of Utah in Salt Lake City. He is the director of the Utah Placenta Accreta program, which sees some of the highest volumes of Accreta cases in the country. He's also an accomplished researcher, some of which we'll hear about today. And Dr. Einerson is one of the founding members of the Pan American Society for the Placenta Accreta Spectrum, also known as PAS squared. And Dr. Einerson is just a tireless advocate for patients in general. And we can see this in his research, in his work on quality improvement and patient experience, and by the overwhelming consensus that we see from his own Accreta patients. We often see Dr. Einerson credited with just the large role that he's played and the positive force that he brings to women getting through this condition. So thank you so much, Dr. Einerson, for your dedication to Placenta Accreta Spectrum, which means so much to all of us. And it is a true honor to have you here with us today.
I'm delighted to be here. Thanks for the invitation.
Awesome. Then we'll go ahead and get started. I've got a few questions for you before we dig into your presentation. And I'd love to give our audience just a little more information about your background. So where is it that you practice?
I'm at the University of Utah in Salt Lake City.
And about how many Accretas do you see a year?
I see consults for about 60 to 70 patients who think they may have Accreta. In addition to doing quite a few telephone conferences with doctors from other parts of the country to get their advice on whether or not they should send that patient to me.
And how has the amount of Accreta cases that you see changed over the years?
We see significantly more today than we saw 5 years ago, and that's way more than we saw 10 years ago. The incidence of this problem is really increasing, and thankfully the awareness on the community of this problem is increasing somewhat.
Awesome. And I'd love to hear a little bit about your facility and how you address the complexities of an Accreta delivery from the patient experience standpoint. So kind of outside of the medical care aspect of treatment, how do you support these moms and families?
Yeah, so when I meet moms, it's usually somewhere in the middle of their pregnancy. They've already gotten some pretty concerning information about what's going on with their pregnancy. And I'm oftentimes sort of the just point person that they meet at the University of Utah. I tell them there's nothing magic about me, but there's a magic in knowing that 10 or 12 or more docs and other practitioners are going to be thinking about them, taking care of them, and trying to meet all their needs through the process. And so that first visit with me is just about clarifying what is going on inside of their body and whether or not I think they need to be worried about placenta accreta and what the treatment options are. We then set them up with a specialty imaging consultation if we haven't already gotten that done, and have them meet with our anesthesiology team to go through sort of the nuts and bolts of what it's going to mean to potentially be awake for part of the delivery and then asleep for part of the rest of the surgery. We connect them with social workers because we know that this is a problem that affects the mental health and well-being of patients and families affected by placenta accreta. And so right from the beginning, we connect them with our clinical social worker who serves as a point person for mental health needs. That person can also connects them with the resources that we have in terms of a lot of my patients come from 4, 5, 10 hours away, and so they get a care coordinator to help them move closer to Salt Lake if they need to, or deal with the difficulties of living far from their family. And so we have a whole team that we set up, and that's sort of the patient experience when they come to the University of Utah before they have their delivery.
That's wonderful to hear how much you think about the complexities. Accreta is such a difficult diagnosis and experience, and really addressing more than just the medical side of the complications, but also, being there to support these women and families is so meaningful. So moving on from there, one area of Accreta experience that's often overlooked is postpartum. So I'd love to hear about how your practice handles postpartum support for moms.
So I think part of postpartum support starts even before delivery, and recognizing that that postpartum is going to probably be different in a number of ways. Some parents and moms haven't experienced prematurity as an issue, and so we address that up front to try to get them prepared for it. We have them come to the NICU and see what it's going to be like when their baby is delivered. We talk through the scenarios of what is likely to happen during their surgical care and try to prepare them as much as possible for when they wake up from their surgery. The postpartum resources that we have specifically are we have more frequent visits in the doctor's office with patients who have survived placenta accreta. They have different needs than if you've just had a C-section or have had a vaginal delivery. And so we check in a lot more frequently. We usually have at least a visit or two in the first 2 weeks to make sure that people are healing well and psychologically that they're adjusting. We also we're lucky enough to provide housing for moms whose babies are here and they don't live close by. And so that is a resource available to them. And then we try to be as proactive as possible with connecting them now. We try to be as proactive as possible with connecting them with social workers and psychologists who can help with the long-term mental health problems that sometimes come along for patients who have dealt with placenta accreta. That's in direct response to stuff that we learned through research here. We recognize that moms were not getting an adequate support team for their postpartum stay. And so that's been a big push for us in the last couple of months to improve that care.
That's wonderful to hear. So many women in the Accreta community, just this experience lasts with them for so long, both from a physical standpoint and just in processing and understanding the experience. So being there to support them is such an important part of the Accreta experience. So I want to move on a little bit to your interest in Accreta. So you touched on this a little bit earlier. Do you think that placenta accreta gets as much attention as it should?
I think it's under-recognized, it's misdiagnosed. It's probably in some cases, it's definitely in a lot of cases underdiagnosed until delivery. And in some cases maybe overdiagnosed. Just because there's a sticky placenta doesn't mean that it's necessarily a placenta accreta spectrum. And so it's confusing. And because it's confusing not just to patients but to doctors, I think that it doesn't really get the attention that it needs to. You would think that something that is the reason for the highest number of hysterectomies, unexpected hysterectomies at the time of delivery, would get the attention it's due. But so far, I think our country has focused a little bit more on other more common causes of major morbidity and even death. And I think now is the time for our community to really reach out and to bring Accreta to the forefront, because I don't think that enough doctors are thinking about it. I don't think enough patients hear the word when they develop the risk factors, and I feel bad that that's the case.
That's so true. So many women, myself included, who have clear risk factors for Accreta, never even hear the word until we're diagnosed with it. So that's something we're very passionate about at National Accreta Foundation as well, is getting the word out, helping those know who could be at risk of it, and really just generating more awareness throughout the community. So how did you end up focusing your career on placenta accreta spectrum?
It was a little bit circumstantial. I came to the University of Utah looking for an adventure and really good training in high-risk pregnancies. And I always was attracted to taking care of very sick moms, like moms even that end up in the ICU. I was always very attracted to that because it felt important. It felt like a place that was oftentimes unexpected. And so I knew I was going to always be I wasn't going to be a doctor who just did ultrasound and saw patients beforehand, but then didn't take care of patients in the hospital. I loved taking care of families facing really the most dire situation you can possibly imagine, having a sick mom in the hospital. And so when I came here, I got exposed to this problem that really was like encapsulated that perfectly. This is something that a lot of people don't understand. This is something that is life-threatening. This is something that is terrifying for patients. And while it sort of sounds weird to say this, and some people look at me sideways when I say stuff like this, I like being that person to be able to walk people through just a totally uncharted territory for them. And I sometimes think of myself as like a navigator or a guide through the desert. I mean, they hear this diagnosis and they're lost, and they need somebody to help them find the way to safety. And that's kind of the role that I see for myself. And there's no better thing in the world than Accreta to be that person.
Oh, that was wonderful. That was so eloquent and heartwarming. Thank you so much. As patients, that's exactly what we need. It's terrifying to get diagnosed with Accreta and have to understand what the condition is, what it means for you, and oftentimes have to make major life adjustments like going to a hospital hours away, potentially being separated from our families. So having someone who can be that grounding force and help guide through is such a valuable thing. So thank you so much.
Of course.
So I'd love to hear, I think maybe you just kind of preempted me with the most gratifying, rewarding part of your role. But if you have anything you wanted to add, we're happy to hear it.
Yeah, I think that there's a lot that's really gratifying, but probably the most gratifying thing is is talking with patients after it's all gone down and after they go home with a healthy baby and a healthy mom. And that isn't the case for everybody, sadly. Not every patient brings home a healthy baby, and not every patient has an uncomplicated course. But even when the best possible outcome doesn't happen, I love having those postpartum visits with patients and the families to talk through how things went, to see how they're doing, to check in, and just to feel like we made it from the super scary super scariness and uncertainty of before to a little bit of stability afterwards, and finally some light of day. And seeing that sort of fog lifted from the faces of patients who are just living in that terrible area of uncertainty, and then just get through it, and to see just a glimmer of hope for the future on their faces really makes my day.
I want to call you out on, you said something that I really appreciate, is you said we make it through when we get through. And I think that's such an important part of the Accreta experience, is making sure these moms don't feel alone. Placenta Accreta can be such an isolating diagnosis and something that is so unroutine that people haven't heard of. So really making sure that that woman knows that not only does she have, her family and friends to support her, but also medical professionals like yourself. And
yep, it's a team effort.
What is the hardest part of your role?
I haven't personally experienced a mom who's died under my care from this, but I know that if I practice long enough, that's going to happen. And so even the wondering about if that could ever happen weighs really heavy on my heart. And even though I know it's a team effort, it's 10 doctors, it's a team. It's a lot of good fortune and making good decisions all put together. I do just really sort of dread that time if that happens. And I do that's that worst case scenario really drives a lot of the protocols that we develop, the care that we give, because I hate the idea that somebody would come into my care and not make it out on the other side. And so it really drives me to lead our team to provide the best possible and safest possible care, so that we don't have to experience that if we don't have to.
And with that, actually, I'd like to propose that we just do a brief moment of silence, just to pay our respects for those Accreta cases that did not work out with happy endings. I know that I see here in the chat, we've got Jackie George here from the UK, and I know many of us are familiar with her daughter's story, and there are definitely others in the Accreta community that we pay tribute to as well. Okay, and with that, I'd like to move on a little bit to what advice do you have for a woman who's newly diagnosed with placenta accreta?
My best advice is for patients to reach out and get as much support as they possibly can, because it's an isolating place to be. Um, there is so much uncertainty associated with this diagnosis, even if you are getting the best possible care. Any doctor worth his or her weight in gold is going to tell you that there's a lot of uncertainty about what's going to happen. We don't know when delivery is going to happen. We can't guarantee the safest possible outcome. And living in that space is really dark. And the only way to get through it is to connect. And so my advice to patients is to connect with your provider. If that's something that works for you, connect with resources through the clinic. If that's psychological or support group, connect with the National Accreta Foundation and other patient advocates. I offer most of my patients a couple of things that NAF helps to coordinate. One is the letters that survivors send to my patients, and that's an important part of connecting. I offer them the website resources that you guys have, which are amazing. And finally, even though there's some overlap here between the NAF website and my patient pool, I offer them direct connections to other Accreta survivors that have actually had our team be their doctor, be their doctor team, or be their team for Accreta care. And I think that that is the best way you can get from the uncertainty and the darkness of a diagnosis to finding some hope for the future, and to look for reassurance and some certainty in a super uncertain position.
And one thing we hear a lot about is the importance in the facility where the woman who has placenta accreta or is suspected of having accreta in the hospital that they choose for where they deliver. And so what advice do you have for women in assessing their facility's capability of managing accreta?
Yeah, I've got a nice slide in my presentation about what you can do as a patient to look for signs that you're getting good care. And I've got another sign just with questions that you can ask your provider to suss out whether or not it's a good situation for you there. It is incredibly difficult to know what quality of care you're getting for Accreta. The differences between even really great places are huge in terms of the approach to treatment and diagnosis. There's not enough research for there to be standards for quality in our field yet. That's a lifetime goal of mine, to help set those standards. But what patients can do is try to have as open and honest a conversation with their doctor as possible to try to understand the resources that are available. Ideally, the place where you're going to deliver is going to be a place that can take care of really heavy bleeding, because that's the most common complication. The way that you might ask about that or know about that is, does your hospital have an adequate supply of blood just in case things get really bloody? I don't want to preempt my slides too much, but I do also think that busier hospitals generally have more of the capability. And so if you are delivering in a hospital that only delivers a few hundred patients a year, they're less likely to have all of the resources that they need than if your hospital delivers, 3, 5, 10,000 patients a year. The smaller volume hospitals generally, this is not a hard and fast rule, but the smaller and less busy hospitals generally have fewer resources to be able to manage Accreta. So you can look up those numbers, or you can ask for them, and then having open and honest conversations with your provider. And if those conversations don't come, look for a second opinion.
Okay, I'm so excited for your slides. So I did have a few.
You haven't seen these before.
I know. I've heard about them, so I can't wait to see them. I did want to get in a fun question or two as well. I was curious, what job would you have if you weren't a surgeon?
I don't know if I want to share this with you. I think I would write poetry.
Oh, that's wonderful.
I would just move to the middle of some canyon somewhere and be introverted and write poetry.
That's amazing. What would people be surprised to know about you?
Besides that, I think people would be surprised to hear that I don't work past dinner time ever. There are a few circumstances, like I owe National Accreta Foundation some slides, so I better get them done. But 360 days a year, I don't work past dinner. And since I started doing that a couple of years ago, it has totally changed my life in a positive way. It makes me a better dad. It makes me a better doctor. And it makes me more effective at work. So that's one thing.
That's amazing. Life lessons from Dr. Einerson here. And in case you guys missed it in the text field here too, I saw Jory did a little shout out. Leave your haikus for Dr. Einerson in the comments.
Please, I'd love to read them.
Okay, well, without further ado, we would love to see your presentation. Thank you so much.
Okay. Can you confirm that that's broadcasting?
Looks good to me.
Okay, awesome.
Sure is.
Very good. So here's some contact information, but I first wanted to just start with a story. I wanted to tell you a little bit about Wendy. Wendy's a patient that I met who's from many hours from Salt Lake City, and she came to me on her 8th pregnancy. She'd had a C-section and then 6 VBACs. So she and her doctor had done everything right to try to prevent Accreta. But she, on her 8th pregnancy, was unlucky to have a placenta that attached down by her only C-section scar. And when she came to me, it was pretty evident that things looked pretty bad on the ultrasound. Wendy was and is an awesome mom and partner. And she was really not excited about having to come and get care at the University of Utah and be away from her family. But because she and I developed a good relationship over the course of a couple of visits, we were able to come to an agreement about her coming down to Salt Lake City at about 30 weeks. And about a week before her planned delivery, when she turned about 32 and a half weeks, she started bleeding. She was only living about 5 minutes from the hospital, or 5 to 10 minutes from the hospital, and was very close. Was living with a relative. And from the time that she called me until the time that she got to the emergency room was less than 15 minutes. In that time, she had completely soaked I think it was her brother's car, in blood, and was covered almost from her chin to her ankles in blood. Needless to say, this was an Accreta emergency. When you have placenta Accreta, the chance of something like that happening to you weighs on your mind every day. And the things that I do as the director of a placenta Accreta program is to try to make sure that this story doesn't happen. But if it does, that we're ready to take care of it. I have a lot of pictures to show you. That is really my only disclosure. And then we always have a funding disclosure. The NIH helps to pay for some of my research. But I also want to just mention to folks who may be a little bit squeamish, and that's okay, that this presentation contains some graphic images of surgery, pregnancy, and bleeding. Not a lot, but I'll try to give you a heads up when we're coming to those. What most people don't find out until faced with it is that Accreta is a life-threatening problem. And it's one that most OB/GYNs don't want to mess with. My colleagues and partners here at the University of Utah wrote the definitive review article on this for the world's best journal, and stated that Accreta is one of the most dangerous conditions associated with pregnancy and is associated with bleeding and other problems that are truly life-threatening. 25 to 85% of patients who have placenta Accreta will require a blood transfusion during their delivery. 50% will require a hysterectomy, at least in the United States. And now, as I mentioned before, Accreta, or PAS, placenta Accreta spectrum, is the most common reason for hysterectomy at the time of bleeding. You can also have a bunch of other things, like your blood doesn't clot. Your ureters, that's the tube that carries urine from your kidneys to your bladder, gets injured. ICU admission is very common. In some centers, it's routine after surgery. And if we know about the diagnosis, 100% of babies are affected by prematurity, which we can get to talking about delivery timing a little bit later. In the most severe cases in the United States, which is, as you know, the wealthiest and most advanced healthcare system in the world in some ways, up to 7% of moms with the worst form of placenta accreta will die. When doctors think about placenta accreta spectrum, they are terrified of it. It's the most dangerous pregnancy complication. Here, a study of differing complications was reviewed from the state of California, and the smartest pregnancy morbidity related doctors give placenta accretus the highest number of points when giving it a risk score. This is higher than other conditions like pulmonary hypertension and some forms of heart disease that are considered to be reasons to never get pregnant, or conditions that we think of as bad, like HIV, AIDS, preeclampsia, hypertension, diabetes, and advanced maternal age, are all pale in comparison to the risk that one gets when they're diagnosed with placenta accreta spectrum. It is the most dangerous pregnancy complication. In 100, and thank you to the National Accreta Foundation, I stole this picture from them. 100% of patients who are diagnosed with placenta accreta require an army to keep them safe and take care of them. So here you see a surgical team of multiple surgeons. You see multiple anesthesiologists, a NICU team, a bunch of circulating nurses and scrubs. And then there's a whole reservoir of other surgical specialists, maybe interventional radiologists or urologic surgeons also ready and waiting. These are cases that hospitals are maximally prepared for. But the morbidity doesn't stop at the time of C-section. This study showed that up to about 50% of patients experienced long-term PTSD symptoms. Think of that. If we had another condition that caused 50% of patients to have PTSD, we'd be throwing money at it to try to figure out how to make it better for patients. In our own studies, this was actually a study that I did with a medical student, so go Brian Grover. We found that patients reported long-term painful intercourse, grief and depression, and anxiety and worry. That's accreta patients in red who have almost double the risk of other patients with complicated cesarean sections of those problems. And those problems persist here in months out to at least 2, if not 3 years. I'm sure that if we asked some patients, it would be even longer. We wanted to know what the lived experience of patients with placenta accreta spectrum was through more than just surveys. And so I had patients who volunteered to talk to our research team to figure out what were the common themes associated with their psychological health and what were experiences they had after a diagnosis of placenta accreta spectrum. And what we generally found was that the diagnosis is terrifying. From diagnosis through the pregnancy and birth and into the postpartum period, patients experience emotional distress, perception Accreta has exploded, in part because it's more common, but in part because we identify it more now. In the 1960s, it was a very rare complication, and today it's not. The top 10, this is my trick slide for all of my learners, top 10 reasons for the epidemic. And everybody says, yep, cesarean section. But also probably the next 9 or next 8 are also cesarean sections. We think that the scar tissue that's caused by a cesarean section is the foundational thing that leads to most patients having placenta accreta spectrum. Not all, but there are some other trends and things like IVF or other procedures on the uterus that can contribute. And in some patients, there are no risk factors. But we do think that the reason that the incidence is increasing is probably because of cesarean section. And cesarean sections are really important. If you're on your 4th cesarean section, your risk of having placenta accreta is 2%. But if you're on your 4th cesarean section and you're unlucky enough to have a placenta attached down low, that's called a previa, then your risk skyrockets up to 60%. So remember this slide. When we're talking about risks later, if you've got a placenta accreta or placenta previa, that's where the placenta sits over the cervix, you have a lot of risk, no matter how many C-sections you've had, but the more you've had, the higher the risk. Placenta accreta is defined pathologically with a bunch of fancy words that talk about the placental trophoblast attached to the myometrium, that's the wall of the uterus, with no intervening layer to keep it, to help it come off at the time of delivery. But really a practical definition is that it's a placenta that doesn't detach, and when you try to forcefully remove it, it will bleed heavily. Diagnosis before delivery is crucially important. In many, many studies, the risk of high blood loss, the risk of needing a large number of transfusions are all decreased when we know what the diagnosis is before delivery. It's also an opportunity for us to prepare the baby if we know the diagnosis. If we know the diagnosis, we know we're going to have to deliver early, and we can give steroids to help reduce the risk of prematurity. Even the bottom right thing here says that even if we don't know about it, we still have to deliver it about the same gestational age on average because of bleeding or other complications. So getting the pre-delivery diagnosis is crucial. But unfortunately, only half of placenta accretas are diagnosed before delivery, and that's in good research that's relatively recent from the UK and the United States and elsewhere around the world. So if pre-delivery diagnosis is critically important and only half of accreta cases are diagnosed for delivery, how can we improve this as a bunch of people getting together to advocate for accreta? What can we advocates, patients do to help? So diagnosis depends on a couple of things. The first is awareness of the problem. It's Accreta Awareness Month, as you heard from us earlier. It's critically important that this diagnosis not be underestimated. And you can help by spreading the word about accreta in your social circles, on social media, amongst your group of friends, and elsewhere. And so I'm thankful to the National Accreta Foundation for being the centerpiece of awareness for this critically difficult problem. So thank you. It's also important that doctors be more aware of this. And so there's been a lot of movement in the last decade to increase awareness of how to make this diagnosis and how to refer patients in. So one of the things that I've worked on at the Society for Maternal Fetal Medicine is actually checklists to help doctors make better diagnosis and to know what to do if they make a diagnosis of placenta accreta, either right before delivery or during their delivery. And so these are, on your end, patient awareness, and on my end, doctor awareness, and we can work together on both. Awareness starts for patients at the time of the first cesarean. After you have a cesarean, you're at risk of placenta accreta, but so few patients hear that. Awareness starts when you're considering getting pregnant after having had a cesarean. Awareness starts even at the very first ultrasound. We're beginning to understand through our research that we can make a diagnosis of placenta accreta in the first trimester. And if that's the case, we can sometimes help to reduce the chance of major bleeding and still preserve the uterus if we know that that is the case. And awareness starts by knowing your risk when you go to see your doctor. The second big theme is that diagnosis depends on knowing the risks. So who is at risk? Patients who are at the highest risk, which is why they get the largest font on this slide, are those who have multiple cesarean sections in their past and have a placenta previa, which I mentioned before is the placenta sits down low over the cervix and in the area of the scar. If you've only had one cesarean but you have a previa, you are still at very high risk. Also, if you've had other types of uterine surgery and then you have a placenta really anywhere, you are at risk for placenta accreta spectrum. So we think that those who have had a fibroid removal or an ablation or IVF treatments even, or other types of procedures that happen in the inside or through the wall of the uterus can cause placenta accreta spectrum. And finally, don't forget about the last two, which is that if you have had a history of a cesarean and your placenta is low, even if it doesn't form a previa, if it's just low, it can be placenta accreta. Finally, if there are any suspicious findings on the ultrasound, when you read your ultrasound report or your doctor gets an ultrasound report back from the radiologist that says, we're worried about how the placenta looks, that is cause for concern. Now, it's outside of the spectrum of this talk to tell you how to make the diagnosis of placenta accreta on ultrasound, but know that this is an area of active investigation at our hospital and at others. In fact, two of my colleagues from radiology are actually our co-authors on the international consensus guideline on the diagnosis of this problem. But essentially, we're looking for a placenta that just doesn't quite look right. It's balled up in the lower part of the uterus. It's lower than expected. It's got dark spots in it that you wouldn't expect, and it sort of forms little shapes that don't really belong where they are at. We're going to oftentimes do a transvaginal ultrasound to look more closely at the area that's likely affected if you've had if you have a previa and a prior cesarean. And we may use Doppler flow to sort of show what the vascularity looks like. None of that is nearly as important, though, as you knowing that just having a previa is risk. So I oftentimes run into cases, either they get referred into us or I hear about them from other doctors, where a patient had risk factors, 2, 3 prior C-sections, or they've had multiple DNCs and underwent IVF. But on the ultrasound that was read at an outside hospital, there was no signs of accreta on ultrasound. The problem with that is that previa is a sign. If you've had a prior C-section and you have a previa, you are at risk and need to have an expert take a look at your placenta. Third, diagnosis depends on getting a second opinion. Second opinions are recommended. So in a ACOG, all of our major national organizations in a 2018 statement said that it is advisable whenever possible for doctors to refer women with risk factors for accreta to centers with experience. If you have risk factors, it's not a routine ultrasound that you're getting in your second trimester. It's a detailed, very difficult to perform ultrasound and interpret ultrasound that should be read by an expert MFM or radiologist who's used to taking care of placenta accreta. Second opinions are also recommended internationally. So the RCOG, which is the Royal College of OBGYNs over in the UK, states that when performed by a skilled operator with experience, ultrasound imaging is highly accurate and that we should be referring women with any features to a specialist unit. Accreta is not routine, and risk for accreta needs to be taken serious in a specialty center whenever possible. But the problem is that as recently as a decade ago, less than a quarter of OBGYNs referred women, even with known accreta, to a specialty center. I have to believe that in the almost 10 years since this study was published that this has improved, but it's also been my experience that we don't get a lot of referrals and we hear about them later, often hear bad stories about them later. So should you get a second opinion? Here's a slide that Kristen and I were talking about. If you have risk factors, so you've had a prior cesarean, or if you have a previa, consider an expert second opinion, particularly if you've had cesareans and you have a low placenta or a previa. And if there's any concerning finding or any abnormal feature that's listed on the placenta area of your ultrasound diagnosis, it's just worth getting a second opinion to make sure that you don't have this really complicated problem. If patients if Accreta is suspected or diagnosed on an ultrasound, do you need an expert opinion, or will your doctor be able to take care of you? Well, I would say you should consider an expert second opinion if your team is not really sure about the diagnosis. That happens. We are often unsure about the diagnosis. I would tell anybody who's seeing me and we're not sure about the diagnosis that it would be worth considering a second opinion. If your team it's not evident that a lot of preparation is going into planning for your delivery, you deserve a second opinion. If you've got placenta accreta spectrum and it doesn't seem like a ton of preparation is happening, you deserve a second opinion. And if it seems like only one person is kind of thinking about you and you got a diagnosis of placenta accreta, that's not enough. Get a second opinion. Consider asking your practitioner, your OB, your midwife, is my hospital equipped for heavy bleeding? How often in a year do you see this problem, placenta accreta? Do you typically refer patients for second opinions? What other members of the Accreta team will I meet before delivery? And can you show me a copy of the Accreta protocol? The most advanced centers to take care of this problem, if you really have it, are going to have quick, easy, confident answers to all of these. The hospitals that are less busy with Accreta are not going to have as good of answers to this. And so the last thing I'll close with is that the diagnosis depends on experienced teams who are committed to learning and improving in the diagnosis and care of patients. There doesn't make sense that we hear in research studies that ultrasound is highly accurate to make this diagnosis, but also that 50% of placenta accreta is missed until delivery. What makes the difference there? It's experience. If you see multiple referrals per week for this problem, you are better at making this diagnosis than if you see it twice or 3 times a year. And so if you're wondering or worried about the diagnosis, if they're not sure, get a second opinion. Accreta diagnosis can be a slam dunk and very easy to make, like it is here. Here's a picture a picture of the uterus inside of somebody's body. So look away if you're a little bit squeamish about that. But you can see here that this placenta is not going to look normal. And indeed, when we got inside, it looked very not normal. But other patients, it's a little bit more subtle. This was a case who was delivered to us with the exact same story as the patient before, 29 weeks, referred to us for concern, had 2 prior C-sections and a previa, and she ended up not having placenta accreta. But to feel confident in that diagnosis took a lot of expert imaging. We had to weigh what is the chance of accreta, and if we're wrong about the diagnosis and we missed this one, is it okay for her to deliver in a small town? So I'm wrapping up now, but I just want to remind you that imaging expertise really matters the most when a diagnostic mistake, especially a missed diagnosis, has serious complications. We get together as an Accreta treatment team and meet monthly to talk about all of our patients that are referred to us. We've got MFMs, that's maternal fetal medicine doctors, radiologists, gyn-oncs, anesthesiologists, nurse coordinators, research staff, fellows, residents, and more and psychologists who come to these conferences. We aim to coordinate and standardize care for our patients, to learn from each other how to make a better diagnosis, and to generate research ideas that are going to change the field to be safer for patients dealing with this problem. You go to our website and you're going to see the huge group of people who are going to be taking care of you. You want to be at a place where there are many experts who can take care of you. I'm going to briefly go through this last part, which is the management of PAS, but the reality is that we need more research to understand what the best treatment options are. Most patients in the United States will have a hysterectomy as part of their treatment, But there's remarkable variation among centers, and you'll get different advice even from equally smart people working in different areas of the country. But let me remind you, the most important part of your treatment plan is whether or not it has expert multidisciplinary care. When you receive expert multidisciplinary care, you will have a better outcome. The research in multiple studies shows that the morbidity associated with your surgery is far less when you get care from a group of people who are committed to team learning and improving their care. So I want to encourage you to be an advocate for awareness. To people who can advocate in this realm, support PAS research, whether it's answering those surveys that I sent you or advocating for more funding for this terrible problem. And do all you can to prevent cesareans, especially if there's any doctors on the phone. I just wanted to close and show you Wendy. I mean, this is when I say the most important part or the most meaningful part of my work is seeing some sunshine on the other side. I mean it. And I've got a drawer full of these cards that I really cherish.
Dr. Einerson, that was just amazing. Bravo. Like, we cherish you. You are such a gift to the Accreta community. Thank you so, so much. That was incredible. I want to like pick out my favorite slides, but it's too many. I did love your slide though on the top 10 risk factors for Accreta. You got me there.
Yeah.
That was a great one. So many, and really that presentation was just such a fantastic embodiment of everything that is so important in treating Accreta, and you just hit all of the values there, including compassionate care. Thank you so much. We're so lucky to have you helping with placenta Accreta spectrum.
Thanks.
That I do want to say as well, I think we had technical difficulties there for a few slides. I saw in the chat that some folks had audio kind of cut out, and actually I was one of them too. I saw the slides, but we couldn't hear you. So Jory, do you know which ones they are? Maybe we'll just go through and show those to Dr. Einerson, and if he wants to say anything specific about those, we can give him the opportunity to do that.
Yes, thank you, Dr. Einerson. I think folks missed maybe 20 or 30 seconds when you were reviewing some of the results from your study and some of the quotes and comments from your patients. That was the part of the presentation I know that folks missed out on a little bit. And we actually also had a couple of comments from viewers wishing that they could see more of the results from that study and that survey. So maybe you could answer those questions and share some of those comments with us and to hit both of those marks.
Sure. Yeah, I can pull up. Why don't I just pull those up and people can sort of read them while we continue to talk, but I'll also make some comments about that. So let me pull my slides back up. Sorry, I put them down. So are you projecting my slide there? So this is the slide that helps to summarize the experiences that were most universal in the patients that we talked about. Those areas in blue are the ones that the themes that people most frequently stated. Some of the examples from emotional distress are here on the screen. And you can see it in these patients' voice that they were just in fear. And they spent so much time just being lost in that fear. Helplessness is another experience of patients So here are those quotes. Uncertainty. This is just one quote of many that that we could do. And in fact, I'd be happy to share the paper once it's published. It's actually in its final stages of being published at the British Medical Journal. So I'd be happy to share that with the National Accreta Foundation folks, just to get some more idea of what these quotes are like from patients. Altered birth experience is something that's really hard for patients too. You go into pregnancy expecting to have a certain type of experience, and then a doctor tells you that you've got a different experience coming, which can be really difficult and a real sense of loss for these patients.
Absolutely. So we've talked a lot today. We've talked a lot today about very severe forms of Accreta and outcomes and things like that as well. So do you want to maybe touch on the positive outcomes that you see and the influence of high quality of care?
Yeah, so I think that the reason I hit so much on multidisciplinary care is because this is a problem that really requires the perspective of a bunch of different people to make the diagnosis. Oftentimes, the doctors who are making the diagnosis are not the same ones who are doing the surgery, and they're not the same ones who are looking at the specimen, and they may not be the same ones who are taking care of you in postpartum. And so that coordination is critically important. I think when we do it the best, patients experience more than just seeing me in the office. They experience care that is expert from multiple different angles. And when we do it the best, I try to communicate with the home doctors so that when patients go back home, they've got some understanding of what happened, and they can understand it from the perspective of a doctor, as opposed to just sort of getting it third hand or hearing only certain parts of it from the patient perspective, which is important, but sometimes doctors just need to talk to use the words that communicate the right information so that you get the best care when you go home. The vast majority of patients who I've taken care of are going to have a delivery around 33 to 35 weeks. They're going to deliver a baby that spends some time with them in the NICU, or sometime in the NICU, but then goes home after a few weeks. They're going to have a manageable amount of blood loss, and most of them are not going to end up in the ICU. Some percentage will have complications. That's just part of this surgery. But the average story for patients in our program is that they're going to deliver sometime in that window. Their delivery, regardless of how difficult the surgery is, may take a long time. But most of those patients are going to come out on the other side, wake up, and find that they didn't have too complicated of a surgical course. So I tell people anything can happen. There are some bad things that can happen to you, but the average patient does really, really well.
Awesome. I'd love to hear about some of your short and long-term research goals.
Sure. In the short term, I want to coordinate studies that happen between Accreta centers to deliver research that will give patients better options for treatment and safer care. And this is, as I say before, it's not rare, but it's uncommon enough that even at the busiest places, we're only going to see 30 to 50 Accreta cases per year. To do meaningful research that will change the future for patients in a positive way, we need hundreds or even thousands of patients to participate in studies. And so it is a abiding short, long, medium, and otherwise term goal of mine to get Accreta centers to coordinate together, to do research, to engage patients in studies that are going to make care better. And when I tell patients who come into my program is, when you agree to participate, if you agree to participate, it's a down payment on the future. You're paying it forward to future moms, future patients who are going to have to deal hopefully with less uncertainty and less potential morbidity than what you had to.
That's so important. Go ahead.
I got lots of ideas, but that's the basic of it. Multi-center research is key.
It's so important for women to use their experience towards making experiences better for future moms. And that's something we really believe in here at National Accreta Foundation. I'm going to do a little shout out and a plug for our story bank. There's Accreta survivors who are watching with us today. If you have not yet submitted your story to us, please do so. And also keep an eye out, join our mailing list. We do get calls for patient involvement in research, and we need your voices, we need your stories so that we can help Dr. Einerson and all the other Accreta experts in making progress towards treating this condition.
Yeah, I think right now, doctors have doctors, rightfully so, and it's not just doctors, healthcare teams have been so focused on keeping people alive that they haven't quite had the bandwidth to say, let's keep people alive and let's not scare them to death. We're going to get there. But raising awareness of how serious this is and how seriously it affects people's quality of life and mental health later on is critical so that we do better.
You know, one of the things I'm really passionate about as well is I've heard stories from different survivors who get treatment all over the country that have these little anecdotes about, well, my hospital did this, and it was this little thing that was so meaningful to me and just influenced my experience so much. And I would love to get to a place too where we can share those and kind of crowdsource what the factors are there and develop a sort of, toolkit or best practices for the patient experience of placenta accreta. And so I'd love if any of you are watching and have kind of those moments of just little things that were done at your hospital or by one of your care providers that just made such an impact in your experience. Please share it with us.
That's a great idea. I'd love to see that list.
We're working on it.
Sure.
So what Accreta research aside from your own are you following most closely?
Oh, I'm really interested to see what the anesthesiology community is doing. I think that they're on the forefront of connecting the surgical team to the patient experience, and I think it's there aren't nearly enough Accreta surgeons in the world who are committed to this, but there are even fewer anesthesiologists who really have made this their life's passion, and yet the anesthesiologists have a critical role to play in helping patients prepare for surgery. And to be honest with you, like I tell patients all the time, the anesthesiologist is the reason you're alive, not me. So they're a critically important part of this. And so everything that anesthesiologists produce in terms of research, I eat up because I think it's just so mission critical to taking better care of moms and helping moms and families have a better experience with placenta accreta. I also really follow the conversations around what is placenta accreta. I think that one reason that we don't make this diagnosis very well is because we don't actually understand the disease well enough. And so there are a lot of physicians all over the world who are doing a better job of classifying this. We're doing a better job of looking at this underneath the microscope and telling us how the placenta behaves and how the uterus can be better prepared so that it doesn't develop placenta accreta. And that stuff is fascinating to me because ultimately I want my patients, when they give me blood to use for research, I want to have a good enough understanding of placenta accreta 10 years from now that we can take that blood, or 5 years from now, we can take that blood and we can develop a blood test so that we're not saying we don't really know. This is a 50-50 shot that you've got this diagnosis. I want a blood test and better diagnostics to make sure that people know in advance. I'm seeing a lot of comments about people who participate in research. I really appreciate you guys for doing that.
That's awesome. Jory, do you want to take a stab at sharing some of the questions that we've received in advance or anything that folks are posing here in the comments as well?
Absolutely. We have a lot of viewers with helpful questions to inform their current experience and also others in the community. Absolutely. We have a newly diagnosed mom, Shelly, who mentions that her pregnancy has been particularly painful, and she's wondering, does Accreta cause a painful pregnancy?
That's a great question. I used to just say no to that until I actually started listening to patients. Um, it doesn't make a whole lot of sense that a placenta problem would cause pain. But the more I come to understand this problem, the more I think that it's a uterus problem as much as it is a placenta problem. And I think that uteruses that are scarred and next to bladders, which are painful, and next to blood vessels, which can be compressed, and next to nerves, which cause pain or perceive pain, those are all really good reasons for you to perceive more pain. And I would have to say that even within just the last 6 or 12 months, I've had multiple patients say this pregnancy is different in terms of feeling than other patients. And sometimes it's a psychological feeling, but oftentimes it's a physical pain. So I believe that placenta accreta is a disorder of that where the uterus slowly starts to open up in patients who have placenta previa and a prior cesarean. And the scar tissue that their C-section caused actually opens up slowly during pregnancy. When that happens, I think there can be pain. And so it doesn't surprise me at all that pain can be associated with the process of placenta accreta. And if you've got placenta accreta, you've got risk factors for pain too. More surgeries, more scar tissue, more pain.
That's really helpful. Thank you. We had someone submit a question in advance about what they've heard about previa, that sometimes, though it can be detected early, it might then migrate and resolve. Would that be possible for placentas that are also affected by accreta?
That is a great question. So previa often resolves, and maybe in up to 75 or even 90% of cases, depending on how centrally located the placenta is over the cervix. It's not my experience that accreta moves very much. It's stuck where it implanted for the most part. But I have had patients whose placentas appear to move a little bit away from the cervix itself, but is still attached to the scar tissue that's causing the problem. And so while placenta previa often moves, I would say that placenta accreta does not, it more rarely moves. And if it moves, it's not going to totally pull away from the area that it's attached to, which is usually down low where a previa is.
We have a mom from England named Charlie who has had accreta in a previous pregnancy, was lucky enough to avoid a hysterectomy at that time. And she's wondering what the risk for her or for patients like her would be of accreta occurring again in a future pregnancy, or perhaps at a more severe level like increta or procreta.
That's a great question, and I have begun to see, on top of the consults that I see for patients who for sure have accreta, I'm starting to see a lot more who had focal accreta, which is sort of a smaller area affected, or who had placentas that were just impossible to remove, and they're worried that they may have had accreta. For patients who we know they had accreta based on a histological or pathological diagnosis, I think the risk of having it again is about 30 to 50%, although it would be highly individualized based on the location and what treatments you had. Part of the problem is that the treatment for most types, the treatment that spares the uterus is oftentimes letting the placenta either go away or sort of removing the part that was affected. And when you let a placenta slowly go away, it's still going to leave the scar tissue there, so you've still got the risk. And when you remove a big chunk of the uterus to take out the smaller part that was, that was involved with accreta, it's not like you just erase all the scar tissue. You cause new scar tissue when you do a surgery on the uterus. And so I think that patients who've had those treatment options to preserve their uterus are at ultra high risk, like off the charts compared to those other charts that I showed in terms of risk in the future, and for sure want to have an expert look at their placenta starting all the first trimester, but for sure at that 20-week scan.
I've seen this many times in our support groups as folks are being newly diagnosed and learning about the condition. Christine asks when it might be necessary for an MRI to be performed as part of the diagnosis. Can you speak to MRIs in the diagnosis of this condition?
We don't know the optimal role, Kristen. I see your smile.
I'm like, well, we have the perfect person to talk about this.
I am an MRI skeptic, but that doesn't mean I'm right. in the words of Brene Brown, I'm here to get it right, not be right. I'm trying to figure out how we can best diagnose this. And in my current understanding of our current technology, MRI can be helpful in some, but is usually not helpful in routine cases. If there is a unclear diagnosis, I would rather have somebody get a second opinion than to just go to MRI, because unfortunately the expertise to read these MRIs is even rarer than to get an ultrasound. So while I think that there are great centers doing great research to make MRI better, put to better use, I think that the majority of places are still going to do an ultrasound better than they will an MRI. And so, if your doc is saying we're not really sure, so let's get an MRI, I think that's reasonable. But you say, well, should I get a second opinion? Should I go to an Accreta specialty center instead? I think that would be a reasonable alternative. That being said, like we've run MRI studies. We don't currently enroll MRI studies anymore, but we have in the past. For some patients who have, including I think some patients on this call, we've done MRIs for very specific reasons because of the location. And so this is where the expertise comes back in. It's not that the tool is better. It's that there's experts who understand the diagnosis and they know which tool is going to work in your specific situation.
I have a follow-up question to Charlie's that I wanted to get in there, kind of a two-part. She had brought up the different severity levels of placenta accreta, placenta accreta, placenta increta, and placenta percreta. There used to be published stats on that, on the incidence proportionally, but I haven't seen that in the past few SMFM updates. So I was wondering what your thoughts were on what percentage we're seeing across those.
That's a great question, and I'm not sure I'm going to have a satisfactory answer for you, because I think our field is moving away from using those three designations, because it depends on the pathologist to tell us what they see. There's a couple of problems with that. The pathologist isn't the surgical team, and the specimen that I sometimes have to nearly wrestle out of a patient's body from scar tissue is oftentimes nothing like what it looked like before delivery. And so we give them a distorted view of what actually existed in the patient's body. There's also just the disadvantage of when you're not the surgical team, it's difficult to know exactly what the specimen's supposed to look like. So I think there's a move away from that and towards classifying what the disease looks like inside of a person's body. And so I think in the future, we're going to be describing this the way surgeons do. There was, thinness here, and there was vascularity here, and the placenta extended to this area of the pelvis, and this part of the uterus was affected. That's probably why SMFM and others are not focusing so much on it. But if you take percreta as meaning the most severe type of accreta, both in the past and by whatever new classification system we use in the future, we think it's actually a pretty great minority of cases that are that bad. It's probably been overestimated before to be 20 or 30%. That's because those get flagged. They're no-brainers. But the milder cases are often misdiagnosed, and I think those are much, much, much more common and probably make up, the accretas and the milder incretas of the old classification scheme, I think probably make up 90% in the general population of cases, thankfully, because the more severe ones are hard.
Sorry about that. You saw my Accreta baby pop in for a second, but it gives me a chance to plug a question that I've actually always been curious about ever since I was undiagnosed, and I had no risk factors. I was one of those, what I'm told, a rare case, undiagnosed with my first pregnancy. I wonder if you could speak to how frequently that occurs. The OB that consulted on my case suggested it's as little as 1% of all Accreta cases.
I think that's probably right. I think that the majority of patients, like 75% or more, will have classic risk factors of cesarean and low placenta. And then a smaller but still considerable size group are going to have something they can point to in their past gynecologic history that caused scar tissue. Some people, I had a bunch of procedures that I didn't really understand from in vitro fertilization, or for some patients I had a septum removed because I was having difficulty getting pregnant. Other patients might just not know what surgery their doctor performed, sadly, on their uterus. But then there's this about probably 1% of all accretas where we can't identify the thing that caused the placenta to do that. And that suggests to me that this is still a diagnosis of mystery. This is still a problem that we don't fully understand. It's possible that, for patients who experience that, there was, some event in their life that they don't recall, maybe an infection or a DNC that caused some scar tissue. But for most of the people who come to me and say I have no risk factors, I believe that they didn't have any risk factors, and that's an opportunity for us to figure out why those cases happen. It might not be the same issue. It might not be the same cause, and there might be multiple causes.
Thank you. Well, I know we have a lot of new fans of yours in the comments who are asking about your consultation on their cases. And so they're obviously impressed by your expertise and grateful for the information you've been sharing today.
Yeah, of course. I see a few other questions. Can I keep going?
We'd love it. Have at it.
I'm happy to keep talking. There's one about, is the standard ultrasound that you get done by a specialist? And that really depends on where you live, unfortunately, and you probably don't have any determination, unfortunately, about whether or not that is going to be done, which is why I stress the second opinion. Most ultrasounds that are performed in the United States that are done at 20 weeks are not performed by placenta accreta experts. And that's partly our fault because we don't train radiologists and MFMs up on this well enough. And we've got to change that in the next decade. But it's also just the reality that the ultrasound has multiple things it's looking at, right? You've got a baby or babies to worry about. And so sometimes people can be distracted. But the vast majority of moms will get an ultrasound done at a place that doesn't see more than a couple of accreta cases every couple of years. And so that's why I think it's so critical to take those, a piece of advice about not sure about this diagnosis, get a second opinion. Have the risk factors, but there are no signs, get a second opinion. Because the more places you get an opinion from, the more likely you are to run into somebody who's got some expertise in it. And you can work with your provider to say, where would you normally, like if you knew I had accreta, where would you refer me to? I'd feel better about getting the imaging done there.
We've got one about whether accreta is hereditary.
I don't think so, but I don't know that for sure. We don't have enough information. Good question.
And I know we had a mom also asking about bed rest. She's midway through her pregnancy, wondering what she can best do to manage it until she gets to that delivery time frame.
Yeah, I think people are often told to be on bed rest, and it's well-meaning advice because this is a scary thing and you don't want to bleed, and you want to, doctors and patients alike want to feel like they're doing something to avoid causing a complication. But if you ask me in my heart of hearts whether or not I think if you do yoga you're going to cause bleeding, I don't think so. I think if you were going to bleed on December 23rd at 6 p.m., probably no matter what you did between now and then, is going to change that. So I'd love to have a crystal ball to figure out when patients are going to have their first big bleed. Unfortunately, I don't. And because none of us do, I think the general advice is definitely don't exercise and you should probably be on bed rest. I personally would go psychologically insane if I was on bed rest, which is another reason that I don't generally endorse it. But there's not any research to suggest that if you're on bed rest, you're going to have better outcomes with placenta accreta. And I don't think there ever will be. That being said, I tell patients to avoid intercourse because there's physically contact during intercourse with the placenta potentially that you don't want to have. And I tell patients to listen to their bodies. If you're having a ton of pain, take it easy. If you're having some spotting, take it a little bit easier. But I've also had patients surprise me and tell me that they're like aggressively downhill biking during their pregnancy, or ranching out in the middle of Idaho, riding a horse all day, every day for until they're 28 weeks. So keep those examples in mind whenever you hear an example about somebody who had a transvaginal ultrasound and then they bled the next day, or somebody who exercised for the first time in their pregnancy and then bled the next day. There's just as many stories of people doing much crazier things and never bleeding a lick until they're delivered, until throughout their pregnancy.
I'm a little bit afraid I'm not going to speak to this accurately, but I think this is a valuable question from Angela. So we know, and we talk a lot, obviously, about the increased risk for Accreta because of the increased rate of C-sections. She asked specifically about the adoption of the low transverse incision versus the old classical C-section incision, and whether that could also be contributing to increases in Accreta rates.
Angela is smart, I've decided. I think that our cesarean technique has something to do with this puzzle, and I don't think it's the cause. I think the number of C-sections is the biggest issue. But undoubtedly, patients of today have more uterine procedures that allow them to keep their uterus than their mothers did and their grandmothers did. And whether that's a DNC or a treatment for IVF or a number of C-sections, patients are just having different types of surgery on their bodies, and that somehow must contribute to the differences that we're seeing in the rates of Accreta. I do think that there's probably something to the fact that when you do classical cesarean, which has all of its own complications, you're cutting through muscle that can be easily put back together, whereas in a C-section, as we do them now, it's cut through the thinnest part of the uterus, which is great for baby, great for mom, reduces bleeding, gives you a chance to have a vaginal delivery in the future, but may not be as good of repair as if there was a ton of muscle around there. So we're working in animal studies, and we're designing clinical research for the future to test out different types of incision repairs that will help to strengthen the lower uterine segment where we do the C-section from, in the hopes that in the future we can prevent it.
Incredible. I mean, I hate to cut this off because these are just such well-informed viewers and asking such great questions, and you're providing such meaningful and insightful thoughts and responses. But I do think that we are drawing to a close of our first Accreta Expert Series. So I'd just love to give you a chance for any final thoughts that you had to share.
Well, the first is join in for future ones, because Accreta experts are going to be joining other awesome Accreta experts who I know, some of them I know, are going to be coming in with their presentations and their ability to answer your awesome questions. I want patients who are survivors to know that their experience and their perspective matters, and that they can help people. And I want patients who are facing the darkness of a new diagnosis that's super scary to know that people care about them.
So well said. Thank you so much, Dr. Einerson, for being so generous with your time today. This has just been fantastic. And Jory, I'll go ahead and hand it off to you to close us out.
Absolutely. We would love, in honor of Dr. Einerson, that all of you commit to take one more action this Accreta Awareness Month. Tell us what you're going to do in the comments before we close out. You might register to donate blood or plan a blood drive, submit your story to our story bank, as Kristen plugged earlier, designate the National Accreta Foundation as your charity on Amazon Smile. You can share your fundraiser. You can still compete for those prizes through the end of the month. Order gear from our shop. Please join our online support groups. They're so helpful to patients and survivors. We've had really creative supporters this month who have helped charity dance classes, designed balloon art, created bakery quality Accreta Strong cookies, so much more. And we can't wait to see all the ways that this community will step up to help prevent Accreta, promote quality Accreta care, and support Accreta patients and survivors. So we will see you next time. And I'm going to put some of these awesome actions that you're committing to up on the screen.
This has just been like a legendary Accreta Awareness Month, honestly. There's just been so much enthusiasm, so much momentum. This has been the perfect just accent to it, including this talk and having Dr. Einerson. We will be putting this video on our website, so stay tuned for having some more information there if you want to go through, look at some other areas again. And as Dr. Einerson mentioned, this is the beginning of a series. So we will be doing more of these. We think it went fantastic, and we'd love to hear your thoughts and have you tune in next time.